Hello and welcome back to the channel. Thank you for watching. I am going to introduce one new segment that I want to preferably keep every Monday, where we discuss about cases that we frequently encounter during our day-to-day practice as obstetricians and gynecologists, as well as for medical students just as a part of their education process, or for those who are pursuing NEET PG. So this week's topic is going to be Hyperemesis Gravidarum, which is a very frequently occurring disorder in most pregnant women. At least it's estimated somewhere between 50 to 70% of women will have some form of nausea and vomiting in pregnancy, which we most commonly cause as morning sickness. So in this video, we'll discuss about the therapeutic options that we have, as well as a quantification score. And along with that, we would want to discuss about how we would go about it at a clinical level, and how do we want to monitor the patients, and what are the things that we want to look for in such patients. Hyperemesis gravidarum is a condition where there is frequent amount of vomiting, and it's so severe that it leads to some amount of weight loss, as well as a change in the electrolyte balance in the body. So you will be seeing a lot of vomiting with a lot of loss of potassium and chloride from the body. It might cause a mild amount of alkalosis, and if you go for urine dipstick testing, then you might see ketone urea. So it's very important to test for the serum electrolytes as well as a regular urine examination for the presence of ketone urea. Most frequently used scores, one that can help us quantify the severity of this vomiting, has been the pregnancy unique quantification of MSS score, which is also known as the puke score. So it helps us quantify the severity of it and whether the patient requires any hospitalization or not. So the least that someone can score is a 3, and the maximum can be a 15, indicating a very severe amount of hyperemesis. So based on that, you can choose an outpatient or an inpatient treatment. I'll leave up the table over here, and you can just read it for yourself. You can pause the video. These are the first line, second line, and third line drugs as mentioned in the RCOG guidelines. So as you can see, it mostly includes antihistaminic drugs in the first line, which includes cyclizine, prochlorperazine, and there is also in the second line drugs, you can see the ones that are more commonly used in non-pregnant patients, including ondansetron and metoclopramide. I'll not get into the doses of all of these things, as they have also already been mentioned in the table itself. And the final line drugs, when all of these things do not work, are corticosteroids. So in the next part, we'll discuss about the ones that we use very frequently in our practice. Over the past 3.5 years that I've been in the obstetrics and gynecology field, the most commonly used drug that we see in India has been doxylamine, which is mostly used at a dose of 40 milligram in the entire day, which is divided over mostly 4 divided doses, and it's usually given with pyridoxine at the same dose. And it has been found in multiple studies that pyridoxine along with doxylamine is a good deterrent to vomiting. So those are the most frequently used drugs that we use on an OPD basis. On an IPD basis, we have been using the second line drugs mostly, which includes ondansetron and metoclopramide. As of now, I have not had a patient who has been severe enough to require corticosteroids, but that is the third line drug that is mentioned, and it's even used for MSS during surgery by anesthetists very frequently. So let's say that we have a patient who has been admitted for hyperemesis in the ward, and we have started them on ondansetron and metoclopramide just to control her vomiting. So the second thing that you want to monitor is whether on starting foods the patient is having that excessive amount of vomiting or not. And preferably we first start with dry foods and not with liquids, because initially there is a reaction to liquids much more than that of dry food, and dry food kind of helps keep your gut motility in check as well. So that's one thing that we would start with, and initially the patient is kept MBM, but we will start with dry foods first and slowly withdraw the intravenous drugs that we are giving the patient, and try to shift them off to something that is orally taken, so that the patient can be discharged and sent home and they can continue with their medications at home. So that's one thing that we do, that's like a clinical vignette if you want to add it. And the other thing would be, if it is still not controlled, then we would want to keep the patient NBM for as long as the ketones are coming positive. So that's one thing. And lastly, if you feel that the patient is well enough, the parameters are good, and the serum electrolytes are improving or are not deteriorating at least, adding multivitamin injections to the patient can also help. So that's been hyperemesis. It's a very short discussion, so I'll try posting one more the next week. I haven't decided the topic yet, but keep subscribed to know about the next release. Thank you.